Hello and welcome to the online training module on engaging families and children in early prevention and early intervention services. This training is a collaborative effort between myself, Courtney Kutzler, Dr. Jeffrey Waid, and the Center for Advanced Studies in Child Welfare at the School of Social Work at the University of Minnesota, Twin Cities. This training module is part of an online training effort that covers a wide range of topic areas in child welfare. This module is divided into 3 parts. First, I will discuss barriers and facilitators to engaging families in prevention and early intervention services. Then we will discuss efficacious models to support early engagement. And then finally, we will discuss specific engagement and interviewing behaviors. Welcome to the online training series. In this section, we will consider the barriers and facilitators that exist for families when mental health services are needed for their children and/or family. Barriers and facilitators to engagement exist at 3 broad levels: the client level, the service provider level, and the community or healthcare system level. Community and healthcare systems have been broken up into separate slides for this presentation. We will move through each of these areas, providing additional details. Starting with barriers. Client-level barriers exist internally to the individual or the family systems. These barriers include the attitudes toward mental illness and help-seeking behavior, concerns regarding the logistics of scheduling and attending appointments, or the confidence that a family has that the service provider will meet the needs of that family. The attitudes toward mental health and help-seeking behavior are identified as a primary barrier at this level. These attitudes can include feelings of stigma and shame of the mental health needs and services. Parents can hold their own feelings of shame or be worried about what other family members might think. Next, the concerns regarding the logistics of scheduling and attending appointments, including the time available for the caregiver, complex intake processes, and transportation barriers. Time can be a barrier due to work schedules, family commitments, and childcare availability. Intake procedures that are complex and tedious become additional barriers for families. Transportation barriers include the length of a commute, especially for rural or remote families. Transportation barriers also include situations where there is limited public transportation options or if public transportation is not regularly available. The confidence families have that a mental health provider can meet the needs is the final category of the client-level barriers. Caregivers who are concerned about the quality of services available or if the provider has the capacity and skill to alleviate the problems experienced by the family have these as barriers. This can also be a barrier when the caregiver or client has a different understanding of what the presenting problem is or the severity of that problem. What other client-level barriers have you seen in practice? The barriers seen at the service provider level can be directly or indirectly controlled through the organization delivering services. These barriers include the processes for scheduling and referral, the flexibility and availability of services, and the provider competency and availability of providers. First, scheduling and referral processes can present as barriers when there are delays and if the process is confusing. The lack of after-hours services, such as evening and weekends based appointments, fall within flexibility and availability of services. This can also include having rigid cancellation or rescheduling processes. Finally, provider competency and availability includes providers that have a limited range of expertise or inadequate diagnostic services available. This may be especially true for families who are in need of a specific skill set by the provider or a specific diagnostic evaluation. High turnover also falls within this category for service provider level barriers. This adds additional variability and inconsistency for families. Last, insufficient or underqualified staff represent another barrier at this level. How have you considered service provider level barriers in your practice? Now we will transition to community level barriers, which are influenced by community norms. These are predominantly including the availability of services within a specific geographic area, and then the community attitudes toward mental health conditions and treatment. In some communities, there may be few or no providers available where a family lives. This results in significantly long commute times or families who opt out of receiving services. Additionally, there may be stigma associated with mental health treatment or conditions. This can be a significant barrier in rural areas where there may be a lack of anonymity for the family seeking services. What do you think providers can do to address any of these or other community level barriers? Health system level barriers are within the context of insurance, accreditation boards, and policy. We have broken this section up into costs, complex insurance procedures, lack of care coordination, shortage of professionals, and few or no culturally appropriate options. The costs associated with treatment can be high and unattainable for some families. These differ between costs associated with primary care versus specialty care services. Further, specialty care, which is usually more expensive, may not be adequately funded for families to engage with those services. Insurance procedures can be complex and challenging for families to navigate. These can include knowing which providers are in versus out of network and the amount of out-of-pocket costs families are responsible for. These out-of-pocket costs may not be funds the families have readily available. Additionally, what services are actually covered or the nature of what is covered are sometimes unknown or confusing for families. Lack of care coordination between providers can be challenging for families. There may be few multidisciplinary teams or insufficient consultation and referral options for professionals as they identify a family's needs. The shortage of qualified mental health professionals in certain areas results in delays receiving care, and sometimes with families deciding that it's not worth it. Finally, the lack of culturally appropriate mental health services is another significant barrier at this level. This can present with few providers being available that align with the key identities that families hold, or providers that don't speak the first language of the family. Either of these situations impairs the access that families have to being able to engage in services. What do you think your role is to identify these system-level barriers? Now we will switch gears to the facilitators. The client-level facilitators are internal to the individual and family systems, just as the barriers were. The most significant facilitator we wanted to highlight is the ability to recognize early symptoms. Families can gain this ability through education efforts that provide information on child development and outreach opportunities to understand what is normal or the scope of what is normal versus what might be something that families need to get support with. What other facilitators do you use to support your clients? The service provider level facilitators are also under the control of the organization delivering the services. This can be indirect or direct, just as the barriers were. These include the categories of awareness, validation of feelings, and clear and accurate information. First, providers and organizations must be aware of the hesitancy families experience when seeking out services. This can include any of the barriers mentioned before. Additionally, different family members may have a different understanding of the problem and the potential solutions for that problem. Providers should seek to understand that within family variability in order to support the different family members. Validation of feelings is similar to awareness but takes it a step further. Providers have the opportunity to recognize the concerns and attitudes of different family members and then affirm them. This can be added into the assessment processes and into treatment plans. Next, providers can give a clear and accurate basis of information about the services available and what to expect in the process of receiving services. This could include information about what diagnostic assessment process looks like and how treatment planning is done at the particular organization. Providers could also let families know the general format of a session, how often to expect sessions, when payments are due, and anything else that is unique to the organizations that families should be aware of. What ideas do you have to use any of these provider-level facilitators? At the community level, there are several activities that can work towards shifting norms. These can include education, confidential spaces, and partnerships. Education opportunities within communities can include education campaigns, information sheets, brochures, or educational booths. Education workshops could also be used that cover information on mental health, treatment, and child development. Although offices where families do therapy are confidential, there are several opportunities for families to be outed if someone notices them going into an office. Things to consider include parking available and what the office space physically looks like. Although this is difficult to change, it could be helpful to let families know they may see individuals they know within the parking lot or reception areas, or even the hallways, and strategize on what might work to make families feel more comfortable. Further, partnerships can be used to connect primary care services with mental health and other specialty care providers. This could help streamline the referral processes. Additionally, mental health organizations can partner with trusted community organizations or groups that could help support with developing community trust in the mental health services and could help the mental health organizations develop a deeper understanding of specific community-wide concerns and the needs of community members. How might you work with other professionals or organizations to increase community-level facilitators in the community you serve? The health system level facilitators are within the context of insurance, accreditation boards, and policy, similar to the barriers. These can include streamlined procedures, family-friendly policies, and continuing education and training. Procedures can be streamlined throughout the enrollment or intake processes when referrals are made between providers both within and outside of an agency and during the assessment processes. Family-friendly policies include options that allow for flexible scheduling, which may be rescheduling or cancellation options. Additionally, services that might be available on weekends or in the evenings can allow families to meet the needs that they have. Continued education and training of providers can be used to keep providers informed on the changing nature of family problems and needs. This should cover skills to identify and address barriers that families experience. What role do you see yourself in to support these and other health system level facilitators? We will now pause before continuing to part 2. In this brief section, we will transition to models that support early service engagement. The models of engagement that we will discuss include family outreach, technology, integrated care, and service navigation. Family outreach is a strategy that combines interpersonal approaches and psychoeducation. Interpersonal approaches focus on building rapport through education, information sharing, and accountability. Information sharing may include resources that might be available in the community for the family. Facilitation of connections would be the added support of helping families connect with those resources. For example, perhaps linking between primary care and specialty care services or other community-based resources. Psychoeducation can cover a wide range of topics. These include, but are not limited to, mental illnesses, mental health care processes, and child development. Psychoeducation can provide families with the basis of understanding what is considered to be normal and to develop common language between the provider and the family. It is important to figure out what families already know about a particular topic before diving into the details. This can help shift what needs to be covered and be more of a collaborative process between provider and client. Technology is another tool that can be used to support families. Technology has a wide variety of uses, including general communication between provider and client, psychoeducation about any of the topics I just discussed, referrals or follow-up between different providers or resources, service delivery itself, and appointment reminders. You may already use some of these tools. Technology can serve to reduce the barriers families face to communicate with the provider or agency, receive therapy itself, and to gain more information about mental health. Integrated care is the intentional coordination within and between organizations. Integrated care has the potential to streamline service delivery to engage families faster and with limited delays. Additionally, integrated care can give providers the opportunity for consultation teams with other professions that are either within the same discipline or in other professions. This can support in creating a deeper understanding of the problem and potential solutions that best serve the client. Finally, service navigation is another option to consider that can support families. This type of support can be delivered in person, over the phone, and online. Each of these options have their own strengths and weaknesses, but flexibility around the options can support the diverse needs of families, either with different families or as needs change for one family over time. Service navigation can be done through peers, paraprofessionals, clinicians, and teams. The primary goal of service navigation is to target and address barriers. There are several strategies that can be used to do this. These include engagement, ongoing assessment, which includes any family needs, barriers, and especially knowing how and when they change or if they do, planning and goal setting, service identification and referral, and linkage and follow-up. The navigator can use these tools to get a better understanding of the family's needs and lived experiences while creating goals and strategies to get those needs met. Follow-up is used to problem solve any emerging barriers and issues while also providing encouragement and affirmation. Characteristics of service navigation are flexibility, collaboration, and client-centeredness. Ultimately, this model works to meet families where they are at. We'll now pause before continuing on to part 3. In this last section, we will discuss specific engagement and interviewing behaviors that support early service engagement. These behaviors include explicit acknowledgment, strength-based, solution-focused strategies, motivational interviewing, and task-centered goal planning. Providers have the opportunity to explicitly acknowledge family attitudes and service barriers. This strategy allows for the provider to affirm and problem solve the needs of a family early in order to maintain engagement. It is also important to acknowledge if a client is voluntary versus non-voluntary. These actions can help build trust and rapport between the provider and the family. Now we will discuss strength-based solution-focused skills. The key principles, engagement strategies, and key questions and statements will be covered. The key principles of strength-based solution-focused work include empowerment, membership, regeneration, synergy, collaboration, and trust. Empowerment is to honor a client's self-determination in the helping process. Mental health providers create a context in which clients can discover the power within themselves to solve their problems. This is instead of a provider being an expert telling a client what to do. The problems and potential solutions are defined in the client's own words. Membership is the collaborative process between the provider and the client. This is done through honoring and affirming a client's perceptions and experiences. Additionally, a provider can recognize the successes and facilitate connections to resources for the client. Regeneration is the focus on wellness and how to achieve it instead of a focus on symptoms and disease management. This is a process of helping clients uncover their own inner and outer resources, figuring out how to leverage those to promote healing. Synergy is when a working relationship is greater than the sum of its parts. Mental health providers and clients each contribute to the working relationship in different ways. Clients bring their lived experience, perceptions, desires, and goals, while the provider brings an understanding of the change process, the knowledge, including theories and methods, and skills, which could be helping techniques. The helping process also focuses on generating that synergy between clients and their broad ecological environment. Collaboration is used to avoid the tendency to provide expert advice or solve the problems for a client. Active listening, empathy, helping clients define and clarify their goals, and find exceptions to the problems they are experiencing can be used in the collaboration process. Trust. This is important, especially to avoid the tendency of providers to mistrust a client's perceptions and statements about themselves or of their circumstances. The client is an expert in their own lives. Engagement in strength-based solution-focused work uses silence, nonverbal communication, self-disclosure, affirmation, empathy, focusing and expanding, exploration of meaning, and a focus on solutions. Using silence is important because clients will need time to process, reflect, and respond in session. Silence is uncomfortable for clients and can be particularly uncomfortable for beginning practitioners who may attempt to fill in that space. Tolerating silence for about 10 to 20 seconds is a necessary interviewing skill. By remaining silent, including redirecting back to the question, requires the client to engage and participate in the interviewing process. With the exception of initial assessments where the worker may need to provide or collect important information, ongoing sessions should primarily be about the client sharing, processing, and reflecting. By remaining silent, the mental health provider gives that space to the client. Nonverbal behavior is used by both the mental health provider and the client. These are displayed in session and will influence the interview and working relationship. Practitioners need to be attuned to how their body posture, eye contact, facial expressions, tone of voice, physical distance, and physiologic responses impact the working relationship. Generating that awareness and being able to modify the nonverbal behaviors when necessary is an essential skill. It is also important for providers to be alert to their clients' nonverbal behaviors, as these provide important cues that can be compared and contrasted to what is being reported verbally. This is particularly valuable in family work, where members will respond to statements made by other family members. Observing and openly responding to clients' nonverbal messages can provide insights to the phenomenon or topic being discussed. Nonverbal behaviors are culturally dependent, so it is important for the provider to understand how nonverbal cues may vary. It is also important for providers to adjust their own nonverbal behaviors if it can strengthen or sustain that working relationship. Consultation with other professionals or providers may be needed for this skill. Self-disclosure is defined as sharing one's personal thoughts, feelings, or experiences with a client. It is okay to selectively and briefly share one's thoughts, and critical reflections when doing so are intended strategies to support the helping process. It is not recommended to share with a client certain experiences like history of sexual abuse or parent-child conflict, as any of these kind of experiences can inadvertently refocus the session to a mental health provider's own needs. Affirmation or complimenting can be done about a client's personal qualities and experiences as it motivates change. They should relate specifically to the challenges that are to be overcome and not be motivated by a desire to be kind or complimentary. Providers must be attuned to the client's feelings and emotions and be capable of communicating and responding to those feelings. Empathy, therefore, is entering into a client's world of thinking, feeling, and acting. It does not mean identifying or taking on or even being lost in the client's world. Rather, it is a way to see and experience a client's world without getting wrapped up in it. Focusing, expanding, and then refocusing is a cognitive technique that is very valuable for providers. This is the ability to flexibly move along with the client, narrowing in on important topics to collect more information, and then expand back out into the broader context. Then, refocusing is used as new areas arise to gain a more complete picture. This is an important technique to keep sessions focused on the client and the needs at hand. This prevents interviews from derailing or a significant amount of time being spent on irrelevant topics. This can be especially important when clients are discussing difficult topics. Exploring meaning is used because solution building focuses less on the process of what happened and how, and more on the substance and implications of the process around the problem and the future solutions. Therefore, amplifying solutions is used since clients may expect sessions to focus on the problems. Providers, after developing an understanding of the problem and its processes, should encourage conversations about solutions and what it will take to get there. This can help counter feelings of hopelessness and despair that a client may have. The questions and statements to use in strength-based, solution-focused work include techniques around problem solving, normalizing challenges, finding exceptions, exploring coping, externalizing problems, and developing discrepancies. Problem scaling is useful for understanding the severity of a problem currently, as well as for making comparisons to previous reports. This can be used to develop a baseline, monitor changes in session, and as well over the weeks of an intervention. A provider could ask a client what their perception of a situation or phenomenon at the beginning and at the end of a session to gain a sense of the problem. This also helps to understand the frequency and duration of problems as well. Normalizing challenges is a useful tool for reducing defensiveness and strengthening the worker-client relationship. This provides an opportunity for the mental health provider to communicate an understanding of the commonality of struggles families experience. Note that providers should not normalize problematic behaviors, ergo child abuse. Rather, providers should use normalization to focus on the context surrounding the problem behaviors. For example, that many parents experience certain kinds of parenting stressors. Finding exceptions recognizes that clients do not experience their problems 24 hours a day, 7 days a week. Finding exceptions allows the mental health provider and client to engage in conversations about what life is like when problems aren't occurring or are handled differently. This provides that opportunity to recognize and raise up the situations when things went right and have open conversations about family processes that work or should be reinforced. When exploring exceptions, mental health providers should go into fine detail about who, what, when, where, and how exceptions occur. This raises awareness in the client of things that they might need to do in order for the problem to go away. It also provides information that the mental health provider can use as leverage in treatment. For example, reinforcing thoughts and behaviors that promote those exceptions. Exploring coping is used because sometimes clients will be so focused on their problems, they will have difficulty articulating exceptions to that problem. When clients are focused on the problem and their experiences with it, it could be helpful to explore what the client does and how to make the circumstances manageable. The mental health provider should listen for coping strategies that are healthy and should be reinforced, like a client taking a deep breath, using walks, meditation, etc., as well as any coping efforts that are contributing further to the problem, like binge drinking, self-harm, etc. Both healthy and unhealthy coping mechanisms can be targeted for treatment by bolstering or developing the healthy coping strategies and reducing the use of unhealthy coping strategies. Externalizing problems is used since clients will often internalize their difficulties. For example, I'm anxious, I have low self-esteem. And externalizing statements and questions can help create space between the individual and their challenges. Problems are described as something outside the individual. For example, what happens when anxiety starts pushing you around? This neutralizes the problem's hold on the individual and creates space between the individual and that problem, allowing for the client to push back on the problems they're experiencing. Developing discrepancy is a motivational technique designed to separate intention from action. Oftentimes, clients will want one thing, but problems stand in the way of that. For example, a problem drinker seeking treatment for alcohol abuse, stating, "I want to be productive in my work. I pride myself in being a good parent." Developing discrepancy is a way to help the client recognize the ways in which their intentions and actions are not aligned and what might need to be changed. This is not a confrontational tactic, but rather a strategy grounded in curiosity. For example, "I hear you telling me you want to be productive in your work. How do you think binge drinking impacts your desire to do well in your job?" Now moving on to motivational interviewing. This is only a brief overview of this technique, and we will cover ambivalence, the writing reflex, collaboration, engagement, and sample questions. A key aspect of motivational interviewing is ambivalence. Ambivalence is a normal feeling when two contradictory feelings exist at the same time in the same individual, usually about the same problem or situation. This could be the feeling of wanting to make a change, but not wanting to disrupt a routine that has been reliable in the past. A common example used is maybe somebody who wants to quit smoking because of the shortness of breath they experience, but doesn't want to quit because of the feelings of relaxation that nicotine provides. Another principle of motivational interviewing is the writing reflex. This is in contrast to rolling with resistance. Clients who experience ambivalence don't respond well to actions that feel too directing. Usually, these actions by providers, although well-intentioned, will bring out the opposite arguments from the client. All of a sudden, a client who is talking about quitting smoking and a provider who's encouraging the client to not smoke will result in the client coming up with arguments as to why they need to continue smoking. When providers feel the need to provide the correct argument or reasons a client should do a certain behavior, it is best to wait for the client to bring this up themselves. A key skill in motivational interviewing is to roll with resistance by being flexible and responsive to the ambivalence the client has. This puts the provider in a collaborative position where they can guide and follow the client. This is similar to the strategies used in strength-based, solution-focused work, where the provider takes the direction of the client and amplifies any change talk the client uses. For example, a client who says they notice that after a night of drinking they have a headache in the morning, a provider can explore that headache a little further. as to how it feels or how does it result in any changes in the client's day. Or if a client is struggling with developing a new exercise routine, but says they have been thinking about using exercise after work, the provider can explore the details about exercise after work a bit further, taking on the guidance of the client. Ultimately, motivational interviewing uses that understanding that the client has the right and capacity for self-direction. The provider is just there to support the informed choices and give any ideas as a sounding board for the client. Sample questions may include, why would you want to make this change? How might you go about it? What are the best reasons? How important is this change and why? Now what? Consider these questions with any of your own behaviors that you are ambivalent about changing. How might they make you feel and maybe be more motivated to change? Task-centered goal planning uses the principles of awareness, prevention, and intervention. A provider and client work together to develop awareness around the client's routines and habits, including any triggers that are known to the client and any behaviors that could be considered high risk. Through this awareness, the client and provider can develop ideas for goals and how to reach them that are integrated within those routines and habits. With awareness, the mental health provider and the client can develop skills focused on the prevention of unwanted or high-risk behaviors. These can include techniques for coping, avoiding an environmental or situational trigger for a behavior, interruption of a sequence prior to the behavior starting, and escape from a situation by physically getting space. As a mental health provider and client develop this common understanding, there are key tools that are used for intervention. The first is the use of SMART, or specific, measurable, attainable, relevant, and time-limited goals. The more detailed and thought out the goals are, the more likely the client will be able to follow through. This is also helpful to know when a goal is actually accomplished, if a client is on track to meet the goal, and to develop ideas for what to do at different points of the goal process. The client and provider then work together to form a plan for the intervention delivery itself. This includes checking in about goal completion, any strategies that the provider and client will use for problem solving, and how they will maintain motivation for change and any ideas for affirming successes. Then the provider will make a plan with how progress is to be monitored throughout the service. This is done additionally in collaboration with the client. This concludes this module. Here are a few references for your information. Thank you for listening to this module.